Welcome to Mic'd Up with Chiro podcast, where I'm your host, Brandon Steele.
And I'm your co-host, Tim Bertlesman.
And you're tuning into the one and only evidence-based podcast made by chiropractors and for chiropractors.
Here's how it works. We'll have a new clinical topic that we dive into each month, and you'll leave with practical skills that you can apply right away.
Well, that's contingent on who's giving the advice, and you'll want to take mine. Welcome to the next episode of Mic'd Up with Chiro with Tim and Brandon. This episode is going over ribs, costovertebral dysfunction. Today we're going to discuss ribs that are out of place. Well, not really. I mean, the actual incidence of ribs going out of place, ribs dislocation, this is extremely rare. But that being said, we still have patients that come in on a daily basis because their ribs are out of place. So we need to be understanding of that, but also understand there are many different types of pathology, musculoskeletal versus somatic, that can cause these symptoms. But today, let's discuss costovertebral dysfunction, along with some stepsisters, dorsal scapular neuropathy, and notalgia paresthetica, because all of these things can contribute to mid-thoracic spine pain. So in a prior podcast, Dr. Bertlesman and I reviewed the difference between scapular neuropathy and also long dorsal nerve neuropathy. Make sure to check that one out. Today, we're really going to focus on that musculoskeletal component being the costovertebral dysfunction. You can also go into our library from our podcast and to check out some different multiple blog articles concerning mid-thoracic spine pain if you want to take a deep dive. But today, let's focus on those ribs that just no one else can fix besides seeing a chiropractor. Just a reminder that if you haven't yet, hit that follow button and share this episode with a friend. It really does help us share our mission here at Mic'd Up with Chiro, reach more DCs just like yourself.
Hey, before we jump into that, we have two interesting studies that came out this month. The first one is about arch instability. So the spring ligament, when that ligament is lax and the arch falls, or when there's first ray instability, that's going to cause not just problems like plantar fasciitis, but it's also going to cause problems like Achilles tendinopathy. Remember, the Achilles tendon inserts just a little bit medially on the calcaneus, so when that arch falls, it starts to create some stretch and ischemia and eventually some sort of degenerative reaction. So supporting that arch is the solution to the process, and we can put arch supports in. But personally, I'd prefer to give the patient an intrinsic arch support, teaching them how to strengthen the muscles of their foot, things like a 30-second stance, or a valet exercise where they're just standing about a foot from a wall and leaning forward to touch their nose against the wall. When they do that, they really get a feel for those intrinsic muscles tightening. That helps to improve the stability and limit the development and the continuance of those conditions. I also use a medial forefoot wedge from humanlocomotion.com. This doesn't necessarily completely support the arch, but it slows the rate of pronation of the foot, which is really the bigger issue here. So this is an inexpensive option that can be stuck on any pre-existing shoe insert. Check out humanlocomotion.com. That's our friend Tom Mashad, the master of the foot and so many musculoskeletal issues. Tom helped us with a recent infographic on selecting the right shoe, whether you need a neutral shoe or a motion control shoe. And it's a lay infographic. Subscribers can check that out in the forums library.
You should really be sponsors for him. I mean, his book, Injury Free Running, is just tremendous. We have no financial ties to Tom, but I just love the work he does. Going the exact opposite part of the body, one of the most interesting things that I found in school was the jaw, so the TMJ, or both TMJs, I guess, in that sense of the word. But there is a new article.
There's two?
What's that?
There's two?
I always love when someone says, I've got TMJ. I'm like, well, yeah, you got two. But 2024 Journal of Oral Rehabilitation took a look at not only TMD, but what are the things we can do for myogenic TMD. And just like yourself, I know that cervical rehabilitation helps with these patients, both manipulation, which is what this study said, is cervical manipulation therapy, or in combination with neck exercise programs are effective in improving multiple pain outcomes in adults with myogenic TMD. So why? Why do we see this happen? It's because those structures, meaning your neck and also your jaw, share the same nucleus in the brainstem, that cervical trigeminal nucleus. The shared input, when there's a problem with one, we can see some peripheral sensitization, or in this case, central sensitization, affecting both. So what that tells me as a provider, that when I have a neck problem, I should be attacking, looking at, evaluating the jaw. And then, of course, the exact opposite is true. If someone comes in with jaw pain, we should be looking at the neck. Something that I think is a good niche thing that a lot of chiropractors can do. When I first came to private practice, that's all I did. I marketed to dentists and oral surgeons on what I can do for those patients with myogenic TMD. And there's a lot of things as a conservative therapist that we can do for these patients. However, that's not why we're here. Today, the condition of the month is costovertebral dysfunction, or as your patients know it, my rib is out syndrome. So Tim, what is costovertebral joint dysfunction? And can you say that 5 times fast?
I can, but I won't waste that sort of time because we got to talk about this abnormal motion between a rib and its connection to the vertebra. And it's a dysfunction. It's not a dislocation. Obviously, that costovertebral joint complex is complex, and it's an overlooked source of pain. That pain not just in the back, but also referring along the rib, even into the abdomen. In fact, healthcare studies that look at the medical field said that 10 to 30% of chest pain is actually musculoskeletal in origin, and the costovertebral joint is a big contributor to that. That's where the rib meets the thoracic vertebra. There's a thin circumferential capsule around that, and then a few radial ligaments that go out over the top. And that anatomy varies just a little bit as far as where that rib connects. The 2 through 8 ribs, the upper ribs, are considered typical, meaning that there's a demifacet. That part of the rib head attaches to the superior vertebra and part of the rib head attaches to the inferior vertebra. Whereas in the lower thoracic spine below the 8th rib, those are the atypical ribs, which means that the rib attaches to a single vertebra, that the whole rib lives right on that spot. And those joints, regardless of what their anatomy looks like, they have rich nociceptive innervation from the intercostal nerve. So those nerves arise off the ventral rami, and that creates a connection for why pain can radiate. It could either be a sclerotogenous referral from that nerve being irritated, or it could be truly radicular pain. Remember that nerve, that intercostal nerve, basically lives in a little groove that's routed on the underside of the rib, and if there's inflammation at the costovertebral joint, that could plausibly spill onto the nerve, and much like a sciatic chemical or radiculopathy, we could get an intercostal radiculopathy in the same way.
Yeah, this is one of the most intriguing things because truly the rib, which is the musculoskeletal component, goes and radiates around in the chest. So you have a structure that does that, but you also have the nerves in between there that can do that, which makes it kind of confusing, So it could be a true musculoskeletal complaint that goes goes from the back all the way into the chest, or it could be the nerve. And this is where things do get a little bit interesting, but I hope in the evaluation section for this podcast, we can make some differentiating both signs, symptoms, and orthopedic tests to make this differentiation, because these costovertebral and costotransverse joints, they have to align perfectly. There's a lot of things happening in the thoracic spine, and unfortunately, if things are not moving properly, just like anywhere else, but that's where we start to see these kind of problems happen, and we need to take in consideration the coupled patterns of motion, because what happens during not only just movement of the actual patient, but we also have breathing happening at the same time. So take this into consideration. When you are breathing, not moving at all, just breathing, that the ribs are still moving, not the spine, but the ribs. So we need to have excursion and expansion of the chest. Now the shaft of the ribs is going to rise during inspiration as the neck relatively depresses or goes down. And there's a lot of things that can happen in this process. Now, whenever we're treating a patient, we obviously need to get the tissue moving. We need to have the patient keep the tissue moving so it can adequately heal. However, in the cases of rib dysfunction and also in the case of rib fractures, we kind of need our patients to stop breathing for that tissue to heal. We don't get too many patients that will consent to that, but if they would just stop breathing, we could get this pain to go away a lot faster.
That is a low compliance solution. Out of the box, but low compliance.
Yeah. We did have to change our informed consent when the patients come in. But really, how do patients develop costovertebral dysfunction, Tim?
Yeah, having a rib cage and living that may be trauma, that you could have been speared by a football helmet or taken a hard tackle. common in football, rugby, things where there's going to be some degree of violence, wrestling, but it could be something that's more repetitive, like golf, swinging again and again, or swimming, a butterfly stroke. All those things are good ways to do it. If you're pregnant, that's another good way to do it, because now the ligaments are loosening up and you've got somebody growing inside that's expanding your rib cage. So kind of a progressive trauma. And most rib problems are that progressive trauma. Postural strain, repetitive injuries, especially repetitive compression or rotation. There may be some degree of degeneration that's impacting it as well, that's just making the joint less functional. And a lot of times it's our patients who have bad posture. They have some sort of a biomechanical deficit that I often tell my patients who have this forward head, forward shoulder posture. It's like taking a piece of plexiglass and then stretching it over the top of a basketball. That's going to create stress points that are eventually going to fail. And so those upper cross syndrome patients, the forward head patients, even our hyperkyphosis patients, and especially patients with dysfunctional breathing, meaning that the ribs are not doing what they should be doing. They're not expanding the way they should, and the patient is not breathing from their diaphragm. They're breathing from all the accessory muscles.
I think I want to slow down just a second and talk about that, because to tell a patient they're not breathing properly is pretty difficult to do, because they're looking at you as they're literally breathing. So sometimes it's fun to have them lay down, and I'll have them lay down first instead of having them do this seated. And when they lay down, put one hand on their sternum and put the other hand on their stomach, their belly, and have them breathe in. So what should happen when you do that is the hand that's on your sternum should not move. The hand that's on your belly should actually rise and go towards the ceiling. And the reason for that is your diaphragm cuts you in half. So as your diaphragm contracts, it should pull downward or pull down towards your belly button. When that happens, it creates space in your chest, creates negative pressure, allows air to rush into your lungs, which is good. Everybody's happy. But what you're going to see and what your patient's going to feel is when they take a breath in, their top hand actually moves and their bottom hand doesn't move at all. And this is dysfunctional. Unfortunately, possibly even what you just said, pregnancy, but also injury, and possibly more even prevalent is aesthetics. Patients don't like their belly sticking out. So what patients have learned to do is they keep their belly in or tucked in, and now they're actually using accessory muscles of respiration. They're not moving their ribs properly, and they're using this inverse diaphragmatic function to breathe, and it creates problems at the rib, just like anything else. If you create a problem in your knee, what's the next problem you're going to have? It's going to be your hip. If you fuse a spot in your lumbar spine, the next joint above it starts to degenerate. So we have this adjacent level disease at every part of the kinetic chain, and if you're not breathing properly, it can create these problems that we're seeing in the ribs.
Yeah, one of the things that you said that was interesting and funny in the past, and that's probably singular, the one thing that you said probably should have started that with, is that all that accessory muscle movement, when you're using the scalenes and the upper trapezius and your pectoral muscles to make you breathe because your diaphragm's not doing what it should, those accessory muscles are going to create problems. They should be firing if you're running from a bear, but if you're not running from a bear, if you're sitting at your workstation or adjusting patients, those muscles should be fairly calm. It should be your diaphragm that's doing the work, and unfortunately, when the patients are using those accessory muscles, they get problems like costovertebral joint dysfunction, and that means they come to see us. The one thing that you can do to dive deeper into any of those is we have a series of webinars. If you go to chiroup.com, and the same place that you find the podcast, you'll find the webinars. We have webinars on lower cross syndrome and hip abductor weakness, and you made a great webinar on dysfunctional breathing. And then we have some on upper cross syndrome and hyperpronation. So all of those 7 really common functional deficits are deeper dives.
Before you go any further, I just talked to Alyssa. There's actually a way to go into that section, and you can figure out which webinars are worth your time. Alyssa, who's our content developer, actually put the picture of Tim or I on the webinar, so you'll be able to see which ones are good if my picture's on it, or if you're gonna, fall asleep during one if your picture's on it.
Yeah, that's why it was a singular funny thing you've said in the past. So how do we determine if somebody has costovertebral joint dysfunction? What's the clinical presentation? What do they look like? Well, number one, it can happen suddenly, that if it was this football or wrestling injury, some sort of a sudden, unguarded, explosive movement, that can definitely do it, but sometimes it's not that traumatic. Sometimes it's more like a coughing or sneezing is when it came on. But a lot of times it was something even more benign, like a reach or a push or a pull. Don't forget that in order for our arm to get out to the extent of its reach, we have to have that anchored to something. So that's our shoulder blade. And our shoulder blade floats on something. So it has to be anchored to something. And it's anchored to the spine via muscle. So when your arm, your long lever arm goes out, that's putting a lot of strain on the costovertebral joints where some of those muscles are anchoring, and that triggers discomfort. They'll come in and they'll have some discomfort, usually 3 or 4 centimeters lateral to the spine. And sometimes, if the nerve root is irritated, we start getting either sclerotogenous referral around the rib cage or true radicular pain around that rib cage. That can be anywhere from a dull discomfort that's focal or burning to something that's really sharp and stabbing. These are the patients that call us in the evenings and the weekends because it's acute discomfort. Unfortunately, it happens with every breath they take. And sometimes patients will say that they feel like they've been shot by an arrow. We're going to do this demo just in a few minutes, Brandon, just before the break. But the shot by an arrow, that's because both the costovertebral and the costosternal joint are paying a price. It's a bucket handle, right? And so when that rib is slightly dysfunctional, it's going to put stress on both joints. And sometimes that pain can come and go. Sometimes there's stiffness associated with it, but they're generally really stiff when they get up in the morning. Usually they're going to see you within a day or two because they're not going to live with this too long.
I'm kind of wondering what TV shows you've been watching. You talked about getting chased by a bear, getting shot by an arrow, like you've been watching Yellowstone.
More YouTube, yeah. Learn all kinds of stuff there.
And this will be more Brandon's experience, so I guess take it for what it's worth, but I have noticed that when I have my patients, when they have costovertebral joint dysfunction, when they lay down, it hurts worse. And I want to make this differentiation. So first is if a patient lays down and makes their pain worse, there is still a possibility for a compression fracture because a supine sign is an orthopedic test that when you lay down, their symptoms get worse, then we need to be concerned about a compression fracture. So age matched would normally be an older patient as compared to costovertebral dysfunction, normally a younger person. So something to consider. So your musculoskeletal complaints, laying down makes it worse. However, neurologic complaints normally get better. So if you have radiation of pain extending into that interscapular space from a nerve from the cervical spine, like dorsal scapular neuropathy, like long thoracic nerve neuropathy, this is actually usually alleviated by laying down because you take the compression off the nerve, and this can help differentiate between a radiating pain versus a musculoskeletal complaint.
And sometimes it's not just the global movement of trunk movement. It can be just rib cage movement, the breathing, coughing, sneezing, those sorts of things will often provoke that discomfort too.
And I think that what you just said is all movement, and that's the biggest piece about this. So does movement make it worse? Because if it doesn't, we do need to be worried about sinister causes. Those are our diagnoses that are our license stealers. Because unfortunately, as a chiropractor, I normally evaluate and manipulate. As a massage therapist, they normally do massage for each person that comes in their office. An orthopedic surgeon evaluate and operate. So depending on your area of expertise, we have this lens and this perspective that everyone has a problem that we're able to assess and to treat. But we also need to understand that not all costovertebral pain is a primary mechanical origin. It can be something different. It can be more ominous diagnosis. We need to be at least considering in our history-taking process and physical examination what's going on in the cardiac realm, what's happening in the pulmonary system, GI, renal system. Is there a viscosomatic referral causing this thoracic spine complaint? Because a lot of things can radiate into the thoracic spine. So one of the common things that we hear, concerning a cardiac complaint is the sensation of pressure or squeezing in that substernal region. Any kind of radiation into the left arm and jaw, we need to take any kind of precautions to see, is this a cardiac complaint as compared to a pure musculoskeletal complaint? And then, of course, looking for fractures. We don't want to go pushing, pulling, manipulating areas that could possibly have a fracture. So if your patient has history of trauma or they're of a certain age that we need to take into consideration any kind of osteoporosis. How old are you, Dr. B?
Yeah, you're still at one funny thing. So don't forget, these problems can coexist. Just because you're certain they have costovertebral joint dysfunction doesn't mean you're certain they don't have something else going on. So especially when it comes to any rib problems and thoracic complaints in general, because they're certainly less common than cervical and lumbar complaints, we want to screen for the red flags. Have they been taking steroids? Do they have something that could predispose them to a problem? Do they have a history of cancer? Could there be some collapse of the vertebrae, either because they're older osteoporotic or because they had a history of cancer? Don't forget that 25% of osteoporotic vertebral compression fractures have a malignant origin. That's a ton of patients. And also looking for the dermatomal rash, that your patient who's had some discomfort and came in with a hot pack burn on their back that happens to follow their rib pattern specifically is not a hot pack burn. That's probably a herpes zoster. So now the nuts and bolts. We want to say, what's the most sensitive and specific tests to determine this problem? And what do we do to get rid of it quickly? Because it is very responsive. So what's the evaluation? But before we do that, let's have a word from our sponsor.
Can't get enough of the information you hear on our podcast? You will absolutely love our platform. ChiroUp helps thousands of chiropractors across the globe simplify the way they practice using our online evidence-based software. It's your one-stop shop for powerful clinical research, simplified patient education, and smart practice resources. Visit chiroup.com, try it out for free. And if you'd like to subscribe, use referral code podcast15 for 15% off 12 monthly billing cycles. No contract required. Offer valid on new subscriptions only.
Yeah, that sounds like a great product.
I would buy that.
Yeah, I would. Nice. I would at any cost. So, number one, what do we do to evaluate a patient who has costovertebral joint dysfunction? Number one, we touch it. So we're palpating the ribs. Is there some discomfort at the costovertebral joint, and is there potentially some diffuse intercostal tenderness along the area? That's possible. It's not necessarily characteristic, but certainly possible. And a lot of times when we palpate the ends of the bucket handle, the costovertebral and the costosternal joints, the patient will say, yeah, that's uncomfortable, and I didn't know that. I just thought my rib hurt out here in the posterior axillary line or the mid-axillary line. So they'll note that those areas are tender where the rib has been moving improperly for a while. A lot of times there'll be some diffuse hypertonicity, potentially even spasm over the top, and the discomfort will increase when the patient moves their rib cage through flexion, rotation, or lateral bending, or just moves the ribs through deep breathing or coughing or sneezing. And again, don't forget, if somebody can't reproduce their costovertebral joint dysfunction with movement, then it's not costovertebral joint dysfunction. We want to look for one of those other more potentially threatening processes, and looking probably means some tests. Sometimes that means we're going to do tests that are unnecessary, but it's always better to explain to a patient why you ordered an unnecessary test that turned out negative as opposed to why you didn't order a test that was eventually positive.
I'm always intrigued by that. You order an x-ray and MRI and there's nothing on and the patient's upset. And one, you always want to be able to explain someone's pain, but we know we can't usually explain someone's pain by an image. However, that's what you want. You don't want anything positive on those x-rays or MRIs. What about motion palpation, Tim? How do you use motion palpation for these kind of patients to identify it?
Yeah, I mean, that would be crucial for me to identify. Is that the issue, that there's going to be some prominence of that costovertebral joint when we challenge it? And especially at the most common segments are going to be T8 through T10, getting down to those atypical ribs where the ribs start inserting onto the singular vertebral body. And because of the coupled motion pattern, those joints are typically more involved than the joints above it. We can certainly see it in the interscapular area, but and oftentimes we'll see more than one area. So not just a single segment. We'll see coexistent segmental joint dysfunction or coexistent costovertebral joint dysfunction at other levels.
I always love the research papers because, unfortunately, when you look at interrelated reliability of motion palpation, it's not high. But it's very high when you talk to a patient and you look at them and you push on a segment and it hurts. It's pretty easy to identify where the problem is coming from. So whether or not the interrelator liability is high, this is a pretty powerful movement for the patient because it tells the patient, I know where your problem is.
Yeah, it's, motion palpation is great because it's basically doing two of the three things that every orthopedic test does. That every orthopedic test you can think of either pushes on it, pulls on it, or makes it work. And with motion palpation, you're pushing on it and you're kind of making it work. The joint's supposed to move, so you're getting 2 out of 3. I think that's one of the reasons it's so tremendous.
Now, traditional orthopedic testing, you can do rib compression where you put their arms to their side and you squeeze in on their arms, or costovertebral spring test is when you literally push on it like motion palpation. And if that reproduces their pain, you're pretty confident you know what area to focus on. Any kind of spinous percussion could be positive, but definitely if you have a positive Valsalva maneuver, this is something that when they cough or sneeze or bear down and they see some increase in pain, or more importantly, start to see radiation of pain extending into the ribs, I would be much more concerned about something like a compression fracture or anything that could cause dural compression. So a positive Valsalva can be positive with a true, musculoskeletal complaint, but if you see radiation, I would really be concerned about some alternate pathology. Neurologic evaluation, they can get some hyperalgesia just because like any other joint, if it's irritated, you may see some nerve involvement, but true sensory or any kind of motor deficits should raise a different kind of suspicion. We should be looking at possibly a disc lesion or something else because that's not common. Another thing to think about is weakness in the scapular elevators or retractors is usually indicating something like a dorsal scapular neuropathy. Notalgia paresthetica, it has a little bit different of a smell and a feel to it. We call this itchy back syndrome, which it's kind of like rotary cup syndrome. Not really a thing, but makes a lot of sense. It's prevalent, so notalgia paresthetica is when we have this cutaneous sensory neuropathy. It causes this unilateral interscapular itching, a little bit of numbness, a little bit of tingling. If we have this underdiagnosed, meaning no one knows what's going on, it can go on for years. You can have people with patches on their back trying to alleviate symptoms and having their husband or wife rub their back every night or being in the door frame trying to rub it out. The problem's not there. So we need to take consideration alternate course of pathology if our treatments are not working quickly.
Yeah, that's an interesting diagnosis, notalgia paresthetica. I remember I go to a dermatologist once a year just for a skin checkup, and I told him, I've got this itchy spot on my chest, and the reason I knew I had an itchy spot is because my T-shirts had a wear pattern there. So obviously I was reaching into my shirt and scratching it multiple times a day. And he takes a look. He's like, I don't see anything there. He said, that's almost always a sub-threshold stimulation of a pain nerve. And I'm like, well, that's funny. The dermatologist recognizes that this happens, but I, as a chiropractor, don't often recognize that same thing. So we wrote a blog, 7 notalgia paresthetica facts for every DC. This is a quick 2-minute read because it's a pretty simple problem, but one that you and I have great solutions for. If you haven't seen that, go to the Chiro Up blogs and check that one out. In addition to those, what are we going to do to help rule out other problems?
Imaging studies are normally not warranted for this initial workup, for just typical costovertebral pain, but if they have those red flags, if you have a suspicion of fracture, any kind of spinal instability, your age over 50, your lack of improvement with conservative measures, any kind of neuromotor deficits, these are going to be the people that we really want to take a closer look. So any kind of red flags, unexpected weight loss, history of cancer, corticosteroid use, those are the patients we want to take a closer look at. What's so interesting, Tim, is this morning before this podcast, we had a meeting with a patient, and this patient saw me, 13, 14 years ago, and to be honest with you, I don't remember treating her. However, that was her lasting memory, was that she had shingles.
Herpes.
We didn't tell her that. We just said shingles. But that's one of the things that I think is so interesting about our profession is obviously we can help the 99% of our patients, but even those patients that we can't help, it's still important to be able to recognize alternate sources of that patient's complaint and then get them in the right hands.
Yeah, and sometimes that's a rheumatologist. Don't forget that inflammatory arthropathies, especially ankylosing spondylitis, is going to produce a costovertebral-like joint dysfunction, that if someone's not able to expand their rib cage like an inch for a female or an inch and a half for a male, when they take a deep breath, we're looking for things that might be making the spine a little stickier than it should be. Another thing that changes the mechanics would be Scheuermann's disease, or now we call it Scheuermann's hyperkyphosis, which sounds a lot better. This is usually a juvenile patient who has a hump in their back, and it's because the vertebral bodies are collapsing a little bit. So if on an x-ray, we draw a line along the course of the inferior end plate and the superior end plate, and those lines converge into an angle, that's wedging. And wedging of at least 3 vertebrae of 5 degrees or more suggests that this patient has Scheuermann's kyphosis, which would be managed differently. And the differential for somebody who has thoracic or rib or chest pain is large. So keep in mind, if movement doesn't provoke the symptoms, you've got a problem.
So far I've learned 3 things today. I hope there's way more. First one, don't tell people they have a humpback.
Unless they're a whale.
Number 2, don't tell them they have herpes. Number
3, don't ever think you're funny.
Then I'm gonna have to leave the last one out. No, it's that the ribs don't go out of place, and that's something that I think is tough sometimes, because a lot of patients are coming in thinking their ribs come out of place because they've been educated in a different way. So sometimes it's difficult as us to retrain that patient that nothing is out of place, but really what we are doing is we're creating motion in a segment that's not moving well, and I think that's important. We don't need to go back and try to re-educate them on everything. However, this joint's not moving properly, we're going to get it moving properly, and we're going to use some other things to help keep it moving. So really, the reason I brought that up is, besides manipulation and praying that it works, what else can we do to manage these conditions?
Yeah, we have the tools for that one, and it's kind of a progression that, number one, we want to get motion back into that joint. So our tools, our favorite adjusting techniques to gain mobility, but then getting the muscles that are part of the problem to loosen up. So our soft tissue works, our myofascial releases, and then ultimately we'd really like to change the reason that those muscles and joints were dysfunctional in the first place. So looking for postural faults and dysfunctions, whether that be upper cross syndrome with a forward head posture, dysfunctional breathing, addressing those. Now, initially, we might have to limit our patient's activity, because don't forget that long lever arm that's attaching the scapula and onto the ribs is going to put stress on that joint. So sometimes they need to keep their elbows at their sides for a day or two and avoid pushing and pulling movements. And if this is somewhere in the mid-thoracic area where a bra strap cuts across, that's going to create a shearing force, and that's going to provoke the symptoms. So our patients who have those mid-thoracic rib dysfunctions, which are the most common areas, especially at the edge of a bra strap, switching them to a sports bra to help diffuse that pressure would be helpful. And then their sleep position. If they're lying in a position on their side that puts a lot of stress on their rib cage, that's probably not going to be helpful either. But basically, when it comes down to it, our number one treatment for the rapid relief is putting motion back into the joint. And if you want any more information about how to manage costovertebral joint dysfunction, if you jump into the Chiro Up Clinical Skills tab, you can look up costovertebral joint dysfunction, or the things that we had talked about as far as dorsal scapular neuropathy or notalgia paresthetica. The best practice resources are there for each of those.
And manipulation is interesting with this type of patient. Remember, it takes a lot more force from the posterior to anterior direction to get those joints to move. So one thing that I'll do for these patients is, well, I shouldn't say for these patients, I'm a A to P adjuster, just the way that I prefer to adjust the thoracic spine, but this is a little more beneficial for this type of patient. But for the patients who can't do that, because remember, laying down causes them more pain because of that pressure on the table. Another thing you can do is a seated manipulation, and that seated manipulation is in Chiro Up, so make sure you take a look at that. We use it for I use it for a lot of pregnant patients. Some pregnant patients don't like to be, have someone, go A to P on their thoracic spine out of a fear of a complication. While that's not the case, we want to make sure we recognize that that concern. So seated manipulation works really well. The another thing about seated manipulation is that it creates distraction, which could be very popular for this kind of diagnosis. Why would I not manipulate the thoracic spine? Well, any kind of infection, osteomyelitis, any kind of a fracture, we don't want to manipulate that. Any metastatic disease, spinal deformity, respiratory disease, we kind of want to stay away from manipulation of those kind of diagnoses. However, when someone does go through manipulation, they normally feel better when they walk out of my office, and that's great. We all shake hands, everybody's got a smile on their face, we have a little parade for them when they walk out the door. However, that's not going to last. it's not going to last because they still have their same job and activity, and they drive their car the same way and sleep in the same position. So one, just like Tim just pointed out, correct those things, but also take into consideration some exercise to help promote some rotation, some lateral flexion, and some extension throughout the back. I use the cat-cow. I do like foam roller exercises and the YTWL exercise that are already in your treatment plan or treatment program within ChiroUp. But I also added the open book exercise. It's one of my favorite exercises to get thoracic spine rotation out of the thoracic spine and the costovertebral joints. So just some things to keep the joints moving. And also remember that if someone's not getting better, well, that's also a sign and a symptom. If someone's having lingering pain and they're not getting better with manipulation, well, maybe it's not just a true musculoskeletal complaint. That could be secondary to something else. So any kind of unresponsive or recurrent restrictions, go looking somewhere else. I don't consider that a fail. That's, hey, we pulled one of the layers back of the onion, and while that was possibly there, they possibly have a joint restriction, that's not the cause of it. So, taking a look at the cervical spine, any kind of chronic interscapular pain could be from the diagnosis we talked about from before. Because unfortunately, when we're not solving the problem, other healthcare providers may be just covering up symptoms. So doing an injection, doing a pain reliever, an anti-inflammatory, while those things can help manage symptoms, they're not actually fixing the cause. So dig a little bit deeper. Speaking of digging a little bit deeper, I did look into Premier Rehab stats for costovertebral dysfunction. Just this year, we've treated it 27 times, so it's very common. In our response rate, we had 100% resolution of pain in the first 30 days. While I would love to believe it's something we're doing amazing in our clinic, I just don't believe so. I think it's just following a simple recipe. It's recognizing it. It's treating it with the most appropriate treatments, and then providing the right exercises. And I think that if you can follow those simple strategies, we can help a lot of patients get out of this quirky type of diagnosis. So before we finish up, I do have two last questions. Oh.
Is this where we do the demo, the shot through the rib?
Yes. Yeah. I was beginning to worry when I saw him roll up with a bow and arrow.
That's just foraging for lunch.
So I have two questions for you. One serious and one not. Which one would you like first, the non-serious or the serious?
Yeah, let's start with the non-serious.
After doing this whole podcast on ribs, I thought to myself, what's the difference between country-style ribs and baby back ribs?
Well, I'd rather do the demo because I have no idea.
I actually didn't either. Interestingly enough, I know I like country-style ribs, but I didn't really know what the difference was. But the difference is, for your education, it's the location on the pig. So baby back ribs, believe it or not, are not from baby pigs. They're just they're the shorter part of the spare ribs. They're from the top of the rib cage, and they're very close to the spine. Country-style ribs are not actually ribs at all. So whoever named that is impressive. So not in the traditional sense of naming, but they are cut from the shoulder and the loin, close to the shoulder blade. So this would be more of your area for your paresthetica, notalgia paresthetica region. So I just thought that was a little fun fact. Now for the more serious question. What's going on with the EMR?
The EMR, awesome. Yeah, we're there. Our billing module's done, which has been super exciting to see. This was a massive process. But imagine a system where once you're done with your SOAP note, which actually only took you a couple of seconds to make a great note, you can submit directly from your EHR and have that remittance come directly back into your patient's account and the money into your bank account. That one of the things that we've created is a truly integrated system, making life easier. We can't wait to get this out to everybody. It's being integrated right now at Premier Rehab to where we're using the entire system. After that, it goes out to our beta testers, which will be within the month, and then on to the profession. And we're looking forward to getting you on board. We have an audacious mission to make our profession the undeniable best choice for patients and payers. And that's going to take a better solution than what's available to us now. And we're hoping that we have that solution. We're eager and excited. This is a system that was designed by our subscribers for our subscribers.
So super excited for that to roll out. And I will say that there's been one common question that I'll get is, why are you guys embarking on this mission? I can tell you right now, it was not Tim and I sitting down and saying, hey, let's develop an EMR. It was after multiple months and really years of our subscribers wanting a better solution. And then we just put it on them. What do you need? It wasn't, I needed an EMR. It was, I need a quicker way to take notes. I need a way to get Google reviews. I need a way to put my exercises in my note. I need a way to have my billing shored up in my office. I need a way to have a schedule that works for a chiropractor. I need a note system that was developed by chiropractors to make my job easier. So whenever people talk about an EHR, it is an EHR. However, it's a task management system for chiropractors to make you successful.
And as you go down that path, I think the biggest thing that they were asking for is a company that stands behind it, that when they call support, that they can get support. And that's one of the things that ChiroUp does well. When you look at the reviews, we work very hard to make sure that our subscribers are supportive, and that won't change with the EHR. Speaking of reviews, if you haven't already, we would really appreciate you to give our podcast a review. Let us know what you think about it. That's the way that our podcasts grow. We appreciate you taking time to listen. We know your schedule's busy. We hope we've been able to provide some information that's useful to you. Look forward to connecting next time and hope that you have a great day.
Hey, thanks for listening. To access more information, visit ChiroUp.com. You can sign up for a 14-day trial. Use referral code PODCAST15 for a special discount after your trial. Offer valid on new subscriptions only.